Thank you, Mimi, for joining today then. So we've arranged this call because we have lots and lots of questions from our teams, intended parents and surrogates alike, with regards to what happens at the clinic phase of their treatment. So I'm Laura, one of the client managers for the people that are going to be watching this. I have a nursing background. I spent 17 years in the NHS. And I come to Brilliant Beginnings as a client manager, having been a surrogate 3 times myself, with my last journey actually being through London Women's Clinic as well. So it's nice to have that bit of insight that we can share along the way. So Mimi, for you, how have you how long have you been involved with surrogacy?
Well, my background obviously is nursing, and funny enough, I was a cardiothoracic nurse in theatre many moons ago, and I am very proud, obviously, to say that I was at NHS at Harefield Hospital when we did the first heart transplant. So that was I was very, very excited. So after that, I left and I went to another private hospital where they were doing just general surgery, and we used to help with the IVF setup as well, like egg collection and stuff like that. And then there was a job opportunity in the IVF clinic because there were no kind of late shifts and evenings and on calls, and I thought, okay, I think I'll go for this. You know, this is interesting. Little did I know that you would be on call 24 hours. So that was very interesting. So I started there, and I was there for a couple of months, and then I thought, really, this is not what I'm used to. You know, obviously, I was always a scrubbing in theatre, and with IVF, the theatre collections just take 5-10 minutes, and I thought, really, this is not for me. So I spoke to my manager, and I said, I think I want to go back to where I was. And they asked me why. I said, well, you know, here I'm more like a receptionist. I'm always on the phone, and there's no patients, there's no nursing. So they said, oh, well, how can we keep you now? I said, well, you know, obviously I can be involved in the clinical area, like seeing patients, talking to them, and obviously if I can do insemination and embryo transfer. So they did train me for those, and the whole thing started being very exciting because at that time we were trying to get the egg sharing program off the ground, and there was a lot of stuff with the HFPA. So it just started being very, very interesting with the egg sharing, and then all the other stuff that you had to obviously comply in terms of HFPA. So I've been involved in the egg donation program for a couple of decades. And of course, before we had the London Egg Bank and the HFA agreed for the altruistic donors to be paid, that's all we did, egg sharing. That was the main egg donation pathway to anybody. And I find that very interesting because I could see all the donors, I could see what kind of characteristics they've got, and then I spoke to the recipients, and I used to match them manually. But this has basically stopped about 4 or 5 years ago when we started having the London Egg Bank scene. And the egg sharing program, we are not doing that many of them, just very few. I think every year we do maybe 10-20 egg sharing, but mostly is egg donors that are altruistically donating to others that they need these treatments. So constantly is changing and evolving, and it's being very, very interesting. Is never a stationary, like, oh, you do the same thing every day. Every cycle, every client is different, and it's a new thing, and that's what makes it very, very exciting. Although my job here as the director of nursing and PR to the HFPA is a lot of admin work, but I really enjoy being involved in egg donation and surrogacy. Now, surrogacy, we used to do a few, and we started it in 2009. We used to do, I think, just a single figure per year. But about 2-3 years ago, that has changed. And I think that was maybe London Egg Bank has been a source that is available and ready now, and people don't need to wait for an egg donor. We don't need to match anybody. They're autonomous. They can go onto the catalog and choose their own donor. And if they need any help or assistance, obviously we are here as well. So that's how we started the surrogacy cases or treatment cycles. And what was interesting, obviously, we never had to quarantine a sperm, but obviously in surrogacy, as you know, all fertility clinics in UK are required to, by HFPA, to quarantine the sperm that is going to be used in surrogacy. And what that means, obviously, we have to do some screening tests. These are virology and genetic tests. It takes about 4 weeks for the results to come back. Then the gentleman will come in to produce his sample, to freeze it, and then 91 days later, or 181 days post-freeze, they have to come and repeat their screening test, and we get the results within 7 days, and then the quarantine time is up, and from then on, we can use this sperm. So there's a lot of involvement in terms of preparing the patients, the pathway, but obviously we're going to go through that later as well, so I can expand.
Yeah, so we've got lots of questions that have come in from master intended parents and surrogates. So yeah, it'll be nice to kind of get through those. So just in terms of, you know, surrogacy in general, as obviously just increasing year on year, and you're very much seeing that in terms of the clinical side of things as well. But just briefly, and we'll go into this in a little bit more detail a little bit later, but in terms of when that team gets to you, what are those initial steps that they need to take?
First step is obviously for the IP and the surrogate to have a consultation with the consultants. Once they've had that, then we've got a group of admin staff here that we call them patients care coordinator. They will be the first point of contact to any clients. They will send them all the price list and the initial information, and they will book them with a consultation with the nurse. Now, that is myself. Obviously, when I see them on my list, pre-consultation, I'll send them an email to prepare them what they're going to be talking about and what is the pathway. During that consultation, obviously, I'll talk about the medications and consent form and any other investigations that necessary for obviously the surrogate. If we are going to use the commissioning mother's eggs as well, then obviously she will have to go through the screening test as an egg donor. But as you know, there is no quarantining the eggs because we're going to use fresh eggs. So, but she will still have to go through the screening test, and for her, we can only start her treatment or do the egg collection minimum of 2 months post initial screening test. So that is kind of the quarantine time for her.
I mean,
so that's what happens.
A lot of our intended parents now do come to us with embryos already frozen. So obviously that gives them a real head start to the surrogacy process. That
really makes it a lot easier if they've got embryos, they want to bring it over, because some people, they might have already done their screening test because maybe they knew that this was the pathway they have to follow. But if they haven't and they've only had the general virology, then when they come to us, they will have to repeat all their screening tests, which is basically genetics and virology, because obviously we have to follow the best practice, which is the BFS. And there are screening tests for virology and genetics that they both will have to do. Now, virology is something that obviously we need to make sure that the lab is ISO or CPA accredited. They can go to their GP, but these days it's very difficult to ask GPs for these screening tests. They do some of them, they don't do all of them, but and becomes very stressful for the clients. But if we have them done all in here, we get the results within 3 to 4 weeks. And then the surrogate can basically start her cycle. But before that, in our clinic, 3-way counseling is mandatory. That means for the IP to have their own counseling, for the surrogate to have her counseling if she's married, then obviously with her husband, and then there'll be a 3-way counseling as well, just to make sure that everybody understands where they're coming from and where they're going. Plus, we require an evidence of legal advice that the IP and the surrogate, they have discussed the surrogacy arrangements. In our clinic, we've got one more step before treating the surrogate, and that is sending a safeguarding letter to all the GP, to the surrogate and the IP separately. And what we say in that letter is that we've seen this couple in my clinic and they're embarking on IVF treatment. Do you have any concern regarding welfare of the child? And we say that we are not expecting to hear from you unless there were some issues. So that is what happens.
Yeah. Okay, great. Great. So that seems kind of pretty standard in terms of what we see from lots of clinics. They might do things in slightly different ways, but generally that's what we see. I was interested to hear about your e-learning modules.
Yes.
This is something that's fairly new for me. So would you just explain what they are?
We have got a platform called Engaged MD, and this is obviously accepted by the HFEA. With Engaged MD, they've got different modules, e-learning modules for different treatment cycle. For example, consent form, surrogacy consent form, IVF consent form, IVF with egg donation. So there are videos that they will go through all these different steps. And we have not linked those with the consent form, but we might do that in future. That means the clients cannot sign the consent form unless they have watched the videos. Because, as you know, they have to have informed consent. So that is what we've started, and they seem to be very popular. I've watched them myself and I thought they were brilliant. So we send the e-learning modules first before we send the consent form, and of course then hopefully that would help them to complete the consent form and they're informed about all the different steps that they need to do. Yeah,
that's great. I mean, having been through this process myself, obviously you have your consultations with your clinician and your nurses, but it sounds like a really positive step to have that available as well, so people can go back and check as to where they're at and what to expect. Sounds really positive. So in terms of a surrogate coming to you, then we've spoken a little bit about kind of what the intended parents have to do in order to get to the point of we've got embryos created. So when a team presents to you guys with a surrogate that's, they've had legal advice, they're ready to do this, they've had their counselling and they're good to go, what steps are next for the surrogate?
The next step for the surrogate, obviously, when they've seen the consultant, they might ask for other investigations. So say everything has been done and we are ready to go. Then we will have another nurse consultation with the surrogate, and I would prefer to have the commissioning couple there as well, if possible, especially if it's a MS Teams, because then we all know what we are going to do. So I'll take the surrogate through the pathway of when they start the medication, when they have to come for their scan, and what happens during a monitoring cycle, especially if they've never been through it. It's very daunting, all these scanning and medications, and how long does it take for them, and how often they have to come to the clinic. We go through all those, and I think we'll talk about that later as well. So there'll be a consultation with the surrogate, and I would always like to involve the obviously the commissioning mum or the commissioned couple, if they want to. So that's what happens. We set the scene, they've signed the consent form. We're going to say, you know, these are the medications you're going to use. We can order it for you. It can reach to your home address, or we can give you a prescription and you can source it yourself from any private, obviously, pharmacies. Most people, they go with us because these days, as you may know, it's quite difficult to get some of these medications, you know, generally, or if you go to a chemist, they might have to order it for you, or they may not have all of it. And recently we've had a couple of cases like that, you know, urgently the clients want some medications. We only keep urgent emergency medications and not just the stock, because they won't let us because of the shortage of obviously these medications. So yeah, that is where we go. And of course, if they've got any questions or queries, they can obviously ask us again. But I know I talked to you about Engaged MD platform. We have got another platform here called Salve app. Now, Salve app, it's something that the clients can download. They can follow all the treatment, they can follow all the appointments, medications, dosage, how often and when to take it. And that is very helpful, obviously, for people, because it reminds them, you know, you have to take your, I don't know, pessaries or your injections or whatever. So that will remind them so they don't forget that they need to take the medication. So we use that app as well.
And is that available? So obviously, because the surrogate at this point is the person who's having treatment, she'll have access to that. But will the intended parents also have access to that?
They don't have access to that. No, not intended parents, just the surrogate.
Okay. And in terms of the workup then for a surrogate, to be even accepted to be a surrogate initially, she needs to have a pelvic scan with you guys before you kind of give the green light. What is it that you're looking for during that scan? And is there a preferred time during the cycle, during the month, that is best for the surrogate to come and have that done?
For the surrogate, when they have the initial consultation with the consultants, obviously they fill in a very detailed medical history. When they speak to the doctor, they go through the medical history, obstetric history, any other things that may need to be addressed. And they will have a scan before they see the consultant, because we want to see that the cavity, that the uterus is fine, there are no fibroids or polyps, and that the ovaries are quiet and there are no cysts on the ovaries, all the stuff that when you do a gynae scan, that's what we are looking for. If there are any issues that they find, then they can ask them to have further investigations. Maybe if the cavity was not very clear, then they might ask them to do a procedure called aqua scan. This is where they can see the cavity by just putting some fluid inside, and then watch that on the pelvic, on the ultrasound machine. I mean, it's an uncomfortable procedure. It takes about 10-15 minutes, but if that is satisfactory and we are happy with the womb cavity, then the next cycle, when they've had the period, then the clients, the surrogate, can start a treatment. It is possible that they might ask for other investigations. Sometimes we ask for a thyroid function test, because we think that can help maybe to stop miscarriages, and maybe they might ask for a blood test to check the blood sugar, again, for early onset of diabetes. But obviously, we don't know. These are not routinely done. Only after consultation with the consultants, they can suggest these things. So, yeah.
Okay, so if something kind of raises a concern, or you know, some of the bloods have come back, and you would request those before you start, just to make sure you've got all your ducks in a row.
That's right. That's right. And of course, the surrogate must be immune to rubella. If she's not immune, then obviously she needs to be vaccinated, and she has to skip a month before she has her treatment. We always ask for a recent smear test or valid cervical smear test as well. You just have to make sure that everybody is safe to start this process.
Yeah, of course. That's really great to hear, and nice to know that everybody's kind of looked after in that process as well.
Yes.
So in terms of just thinking about the intended parents again, we work with straight couples, same-sex couples, and we often get kind of straight couples that come to us that really want to be able to try and use their own embryos in terms of eggs and sperm. Do you have, I mean, is there a generic cutoff point in terms of age for when you would use an intended mother's eggs, or is it more by case by case?
Generally, we go by obviously the guidelines that the donors has to be under the age of 35 or under. But if somebody has been 37, for example, and they created embryos at that age, then it's something that the surrogate has to be informed, and what are the pros and cons, what are the success rate, obviously. Then there are issues around maybe PGTA, maybe somebody wants to do a pre-genetic screening test, that kind of thing. So yes, we have done it before for somebody who's been, over the age of 35. In fact, over the age of 37, we probably say, would you like to test the embryo? Is entirely up to the surrogate and the commissioning couple, but this will be discussed with them and they come up with a decision.
Okay. And if intended parents wanted to create embryos and the intended mother was over 40, for example, would that be something that would be advised against given her age?
We would, we have never had anybody around that age, but it will be obviously case by case.
Yeah.
It's something that, what are the chances of success, even if she was having the embryo transfer herself, and would they do a pre-genetic screen test on the embryos, and what would the surrogate feel? How would they, because they want to be successful, they want to reach to that goal, as soon as possible. But after the age of 42, we certainly don't even offer egg collection to routine fertility patients. So it's something that it is very rare, but it will be obviously discussed with the surrogate and the commissioning couple to understand what are the success rate.
Okay, that's great, thank you. So just moving on then to some of the questions that have been posed to us from our clients and our surrogates and people that we work with. Do you have any kind of clinical criteria that surrogates need to meet in order to be a surrogate?
We have an aging criteria for both surrogates and commissioning mother. They have to have the delivery, the surrogates, by the age of 55. You might think, are there many surrogates at that age? We've had one or two, and the same with the age of the commissioning mum. Obviously, we will have to check her medical records and make sure that it is okay and is safe, and she can look after the baby. So that kind of thing. So this is all to do with the consultation and what happens during the initial consultation and what the consultants decide. But we have a cutting age, obviously, at 55. And as I previously said, if there is anything else for surrogate, for example, if we have to check the womb, if we have to check a thyroid function test or anything like that, these are the screen tests that we need to do. Other than that, healthy, past, make sure that the pelvic ultrasound was okay, make sure that the counseling went okay and everything is secured and explained, and that's it basically.
Okay, so it's interesting you mentioned that there is criteria for the surrogate and the intended mother. But given that we have single parents coming through now, and we do have single fathers looking to become dads, would they need to meet that same age criteria?
No, for men, if we are obviously, and if it's a female single person, then she has to meet that criteria, 55.
Okay. But if it's a male single
if it's a male,
parent,
our criteria is 70, age 70.
Okay,
but
so
obviously, as you know, with age of 40, after 43, 45, the risk of abnormality, it increases in a sperm and embryos. So again, we've never had anybody of that age coming requesting to have a surrogacy, but we've had clients that they want to use their own gametes in their own treatments, and we have done that before.
Okay, I just think in terms of the difference there between a single mum coming and saying, I would like to have a child, I am pushing 55.
It's fine, we'll accept her. But the thing is, we cannot accept somebody who is 55 if she hasn't got her own gametes frozen or embryos created before, because one of the gametes must obviously be linked to the commissioning couple. That is, she can't use donor eggs and donor sperm.
Yeah, okay, great, thank you. So if something was kind of raised within the obstetric history of a surrogate, for example, Mimi, and you potentially would request an obstetrician referral before you were to start treatment, what would you be looking for in terms of that consultation from the obstetrician?
The obstetrician will go through the obstetric and medical history of the clients, and they will do a risk assessment in terms of pregnancy and delivery. So if he feels that this is a high risk pregnancy, that he might advise against it.
Okay, so you would be looking for that advisory information from them.
Yes.
I guess that would also be to ensure that the surrogate has all that information for her to also make that
obviously
choice.
We will let her know that this is what is required, and she needs to have, we will tell her what it is that we are certainly looking for. Then she will have to get all that information to make sure when she sees the consultant. She can go, if she's got her own obstetrician or her own gynecologist, they can write to us and tell us. Otherwise, if they haven't got anybody, we've got consultants from UCLH that can help us to refer the patients to them to do a risk assessment.
Okay, lovely. And how long does an average treatment cycle take?
An average treatment cycle takes around 3 weeks, because normally we start the monitoring cycle from day 2, day 3, even day 4 of the period of the cycle. And it takes about 10 to 14 days before the lining of the womb is thick enough and it is of good quality before we can start the progesterone and then plan either the egg thaw or plan the embryo transfer, which will be 6 days later. So approximately about 3 weeks for the embryo transfer to happen, and then 10 to 12 days later they can do a pregnancy test to find out the outcome of that treatment cycle. And hopefully when she's pregnant, then we scan her 3 to 4 weeks later to see obviously a fetal heart, early pregnancy fetal heart, and after that she can be discharged to her GP for antenatal care.
Right. And in terms of kind of prioritizing or optimizing the surrogate's kind of ability to cycle and kind of build that womb lining, how long do you suggest that she not be on contraceptives?
We say a couple of months. They have to go back to their normal period, and really, because we are not going to get her eggs or anything like that, we're just looking for a lining of the womb. As long as she's had a normal period, then we are fine. It is possible that sometimes people are not having a period, and of course then we need to investigate, you know, other blood tests and stuff like that.
Yeah.
But as long as she's had a normal period, 1 or 2 cycles, then she can start.
Okay, great. And in terms of how many times the surrogate needs to come to the clinic during that kind of 3 weeks during that cycle, how many times would she need to do that?
She will come for a baseline scan around day 2, day 3, day 4, and normally the second one is about a week later, around day 10, day 12. And by then, by the second scan, we know that where she is, like the lining, how thick it is, what's the quality, and perhaps we can then book the procedure for the transfer or the egg thaw. But sometimes some people's cycle are different. They might need a little bit more help, maybe another scan, maybe 3 scans within 14 days. By then, hopefully we can set up the procedure for the embryo transfer. So I would say 3 to 4 visits to the clinics is necessary, yes.
Yeah, and that's kind of, you know, with potential for more if needed during that time.
Yes.
And in terms of logistics then, so some surrogates aren't always local to the clinics that they're having treatment in. Would it be possible for a surrogate to have those screening scans locally, and
yes,
for the results to be fed back to you guys?
Yes, they can have their scan locally, they can have their screening test locally, and send us the results, and then we advise them what to do next. Yes.
Okay, great. That's always kind of a, you know, something that we talk to a lot about our surrogates.
Yeah.
You know, the logistics isn't always easy, so kind of making that route as easy as possible is always handy.
Yes, sure.
So in terms of COVID restrictions, I know this is a really ongoing topical discussion. Do you guys have any restrictions at the moment, and what does that look like for teams?
We go obviously with the government's guidelines at the moment. Fortunately, everything is back to normal, more or less, but we do ask for lateral flow test when the surrogate is coming for her procedure, to go into the procedure room to have the embryo transfer. And if she has got anybody who is obviously going to be with her in the room, we allow one other person to be in. They have to have the lateral flow test as well. Otherwise, coming to the clinic, we obviously ask you, have you had any symptoms and stuff like that. There's a questionnaire that they fill in, but there won't be any tests. We did used to have ask the clients to have a PCR test for COVID, but we've moved away from that. At the moment, it's lateral flow test on the day of procedure for the surrogate and one other person if they want to be in the same room. Okay,
great, lovely. And in terms of communication with the surrogate and the intended parents from the clinic, you've mentioned your Salve app, which sounds pretty good from the surrogate's perspective and prompting with those medications. But in terms of kind of feeding back from scans and consultations to the intended parents, if they're not there with the surrogate at that time, is that something that you would do? Would you feed back to the intended parents?
We do not feed back to intended parents. We ask the surrogate to be in contact with the client, with the intended parents. But if they're coming, and sometimes, a lot of times actually, one of the intended parents would like to accompany the surrogate when they come for a scan and stuff like that. And if she's happy for the intended parents to be in the scan room, and when we scan her and talk about the finding, then it's fine. Otherwise, we will talk to the surrogate, and she will be in contact with the intended parents.
And if the surrogate wasn't at all happy kind of giving feedback, potentially, is that something that you guys would help with?
Yes, of course. We want to know obviously why. fortunately, we haven't had many of those circumstances, but because of confidentiality and GDPR, as you know, we do not want to disclose any information about the surrogate to the intended parents. But is a trust between them, and and I think if somebody calls like an intended parent, say, "Oh, what's happening?" and it has happened, we always say, "Please, contact your surrogate, and if you've got any issues, please come back to us." So
but if you had consent from your surrogate to be in touch with them, then that would be okay.
Yes.
Okay, so there's kind of a big discussion within our kind of surrogate group sometimes with why some people go for a natural cycle over a medicated cycle, and what the differences are there.
With a natural cycle, you have to have a very regular period, and you have to be able to detect your LH surge to make sure when you're going to ovulate. So and some people, they don't detect their surge, or they're not completely sure how to do it. So what we do here, if they're going for natural cycle, this is something that it will be discussed with the consultants, obviously, at the time of consultation. Say somebody was going for natural cycle, we always ask them to let us know when they start their period. If possible, come and have a scan, and then from day 8 onwards, try to do the LH test, to ovulation test, and when they get a surge, to let us know. Or we might say, no, we want you to come on day 10 or 11 for another scan, so we can monitor this natural cycle. And if they don't pick up the surge, or if they've got experience of that, then we might have to make them ovulate and give them a trigger injection. Now, it's most of the time, even in a natural cycle, some consultants would prefer to give some progesterone pessaries as well. But obviously that will be discussed with the surrogate. If they're young and they've got good lining and good texture and all that, then they might say, okay, go totally natural. But it's very, very rare that is absolutely natural with no progesterone during luteal support. With HRT tablets, obviously, we've got very good results. Plus, it's a lot easier to make sure that the timing of the transfer is optimum. And the drugs we use during stimulation or HRT cycle is some estrogen tablets for 10 to 14 days, and then obviously progesterone pessaries. And it's possible sometimes that we might have to give a little bit of a boost for the progesterone, and some consultant will ask on the day of embryo transfer to do a progesterone test, blood test, and if the levels are at a certain lower or above what he has suggested, then it's possible that they might have a top-up of an injection of progesterone as well. And they come in 2 different types of injectables. Some of them are subcutaneous, which is under the skin, into the fat, and some are intramuscular, which is into the muscle, and it's quite painful. So they will discuss all those logistics with the clients, and to see which one they would prefer. And sometimes even the consultants, they've got their own preference which one to take. But the thing with HRT cycle is that when the surrogate is pregnant, they have to take all these medications up to 12 weeks of pregnancy, which is a very long time. And some of them, they're not feeling very well on it because of the progesterone and estrogen. So I think that's the only thing, that they have to be on the medications for quite a long time. But I would say 90% of our cycles, the surrogacy cycles, are HRT cycles.
Are medicated fully. And I, having done this quite a few times myself, I know that from clinic to clinic, those protocols change. and what medications you get are really different depending on what doctor you're seeing and who you're with. There could be medications up to 5 times a day in some of those protocols. So the Salve app, where you say kind of setting those timers, would be a bit of a godsend, I would say, for lots of people. So we're going through that.
Yeah, I think, and you think you're doing this every day, you remember, but you easily forget, and you think, oh, maybe I've done it, so there's something to, and nudge you and say, you need to do it now. Or
I mean, the Salve app sounds great. I think we sometimes get surrogates say, look, I'm really not sure about these injectable medications, and mainly it's those IM injections that people struggle with, because they are a bit sore and not overly nice.
No.
But do you have support for surrogates doing that themselves?
So with the injectables, we have obviously videos that we can send to the patients, and they go step by step how to do the injection, how to prepare and how to inject. But if they're going to do it themselves, if it's an intramuscular, it's a very difficult one to do into your buttock, and they have to put it in their thighs, which is very painful. But we have videos. We offer them, if they've got any issues, to come and see the nurse, so the nurse can go through the injectables with them. If they still have issues and they've got needle phobia, they don't really want to do it, then they can come to the clinic and we will do the injections for them. But obviously there's a charge for that. But if there are intramuscular injections, they're not going to be daily. They'll be one every 3 days. But it's the subcutaneous one, which is a lot easier to do, then they are daily. So yes, we've got support for anybody, for surrogates or any other client, if they are doing injections. But unfortunately, the only problem we might have is the weekends, because we've got the skeleton staff and we don't have enough people, because they're all in theatre and recovery. And if somebody comes in, they might have to wait a long time to have the injections. But people are very resilient, and I think they want to help and do their own thing. So if the surrogate is got a partner, then maybe they can help them, or sometimes even the commissioning couple helps. Yes, but there are ways that we can help. Sure.
Great, lovely. And generally, the advice that we give to all of our teams is, don't expect this to work first time, because it could take a few attempts for this to happen for you. But what are the timescales between cycles?
We always skip one cycle before you start a new treatment cycle again. And of course, if a cycle has not been successful, the clients always have another consultation with the doctor just to review the medications. They can have a counseling session, because remember, these procedures, these processes, very, very emotional, costing so much, there's a lot involved. So I think we feel that they should skip a cycle and start again, because to do it back to back is just is very, very difficult. And as you said, what if the next cycle is not successful? And people always think, oh, have I done something wrong? What did I do wrong? I'm saying, no, it's nothing to do with what you've done or you haven't done anymore. Once the embryos are placed inside, they can do so many different things. So, but one cannot move away from feeling that maybe I could have done more, maybe I haven't done what I was supposed to do. So, so they have a month gap between each cycle.
Okay, that makes sense. And in terms of the different sorts of teams, that surrogacy teams that come to you guys, you must see them from all different areas. So obviously, Brilliant Beginnings, we have teams that are working with you guys at the moment, and the various other support agencies in the UK. Do you see much of a difference to those that come to you independently?
Not really. I think independently, obviously, if they come from an agency, then they sort of organize all the counseling session maybe and the legal advice. But if they come independently, then we organize that. Obviously, we advise them where they can go for legal advice, but they can see their own, obviously, legal advice team.
Yeah, lovely. Right. That's pretty much it for us, maybe in the question. So just kind of to round up then, in terms of what it is that people need to do when they kind of get to you.
So obviously initial consultation with the consultant, any investigations required, that has to be completed. A 3-way counseling is mandatory. Quarantine a sperm, obviously it's again mandatory requirement. Whether it's donor eggs or commissioning mother's eggs, then obviously we have to plan for her egg collection. If it's London Egg Bank, then they can visit the catalogue and they can choose their own egg donor if they need any help. Or somebody emailed me a couple of days ago and he said, I really need to speak to somebody, because this is a little bit like, I need that help. So yes, you know, you want to speak to somebody, you know, it's not just do it yourself. So there is help there as well, and you can contact the London Egg Bank and see if they can help them with, I don't know, characteristic. Would this suggest anybody else who probably fits the family, you know, that kind of, that is available. Of course, legal advice and safeguarding letter to be sent to their GP, completing obviously all the HFA consent form and in-house consent form. So there are about 8 or 9, 10 different steps in place before they can start the treatment. But at each stage of the treatment or pathway, they can always email me. I do send massive emails to clients, and sometimes they say, don't email me, I don't want to know, just talk to me. But I think it's important, they can have the email, they can always refer to it. We've got the Salve app, we've got the Engaged MD. So I must say, I don't have a lot of people coming back to me and say, what is the next step? Because you know, it's all there and they can go back to it. But different steps, we've got different emails that can explain the next round of, you know, treatment. So everything is not in one go, because it can be quite daunting, because there's so many different things they have to do.
Yeah, of course. Amazing. So Mimi, that's been really, really helpful, and I'm sure lots and lots of people will find that really insightful in terms of starting their journeys too. So thank you for your time.
Well, thank you very much for talking to me. Anytime if there's anything else I can help, please don't hesitate to contact.
Brilliant. Thanks very much.
Nice to speak to you.
You too. Take care.
Have a good day. Bye-bye.